My name is Tom, Dr. Tom Bamford. I'm the Medical Director of Care Fertility in Manchester and Sheffield. So I'll be talking to you today about LGBTQ plus pathways to parenthood. So lots of different ways that couples in all shapes and sizes can have fertility treatment. So hopefully we'll go through an option that might be interesting to you today. And we'll have time at the end just to go through a few questions. So we'll go through some of those and George will come on to quiz me. So we'll make a start. So today, the main treatments that we'll be going through is IUI and IVF, shared motherhood, or sometimes called reciprocal IVF, surrogacy, fertility preservation, and different donation options and legal support that we provide. And this is just to say that we know that every journey is unique, so it's very difficult to provide accurate information that's tailored for you, because that's what is going to happen at a consultation. But what we'll do today is just go through an overview as really kind of the general themes of what we offer for different couples or single patients. So the first thing that we're going to start with is same-sex female pathways. So the most common way for same-sex couples to have fertility treatments is with IUI, or intrauterine insemination. So this is a treatment where we prepare sperm, so donor sperm in this case, in the lab, and then we inseminate it into the person that wants to carry the pregnancy into their uterus. And the process is relatively straightforward. So a lot of same-sex female couples choose to do it this way because it's a little bit more natural, it's less invasive, and the majority of same-sex female couples are not infertile. They've not got a fertility problem, which means that they would need to have IVF, and that's why IUI in these patients or couples is really successful generally. Now, in terms of the process, what is involved is some fertility tests at the start. So generally, we advise checking that your tubes are open. So the first thing that we want to check is that you've got a regular menstrual cycle. So if you've got a period every month, most people will be ovulating and releasing an egg. So about 95% of people will be releasing an egg if their cycle length is shorter than 35 days. And that's what's really important for IUI. We want to make sure that you're releasing an egg on your own. Now, we can sometimes give you medications to help that process and help you ovulate, and that's either with tablets or injections. So if you don't have a regular cycle, there is always ways that we can try and help and make you ovulate. So they're part of the fertility tests. And then we also want to make sure that the tube is open so the egg and the sperm can meet. Now, the most common reason for tubes to be blocked is previous chlamydia infections is the main one, or other sexually transmitted infections. And actually, a lot of women, the vast majority of women, have had chlamydia before, but probably less so in the same-sex female population. So you don't need to have your tubes checked. You can choose to have treatment as an IUI process, and you say, well, I've never had any of these complications. I've never had any of the causes of blocked tubes, such as surgery or something called endometriosis, which causes scarring in the pelvis. So I'd rather just go ahead with the IUI process without testing, and that is also fine. So this is just something that we would offer if you wanted to. And actually, national guidance says that you don't need to test the tubes until you've had 3 IUI procedures and they're negative. The reason that we say to consider it earlier is that, of course, you don't want to go through all those cycles of treatment and then find out that your tubes were blocked, and then you've wasted a few months of treatment and all of the expense and emotions associated with that. So we've checked that, and then you've got a donor from our bank, and we'll go into a bit more detail about donor sperm in a little bit, but then you've been matched to a donor, and then what we do is you would phone up with day 1 of your period. You come for a scan generally around days 10 of your cycle, and what we want to check on that scan is that you've got a follicle that you're about to release an egg from, and that your lining is nice and thick, ready for implantation. So it might be that you're not quite at a stage for ovulation, and we might bring you back for another scan. Sometimes we do blood tests, or sometimes we just give you urine ovulation kits, and it really depends on what we see on that first scan. The IUI is performed when we've detected ovulation. So that's either with the blood tests or the urine ovulation kits. And generally it's performed the day after ovulation. Now, it might be the case that we give you a trigger injection. So a trigger is something that is a hormone that makes your body ovulate and release the egg. So you don't have to have that, and the pregnancy rates are no different with or without it. But sometimes we give it for practical reasons. So say you're having a treatment in a clinic that doesn't open on a weekend or doesn't open on a Sunday, we might want to miss the falling on a Sunday. So we might make you ovulate slightly earlier. So that's why we occasionally use the trigger injection. After that, just over 2 weeks after, it's about 2.5 weeks after for an IUI procedure, you'll do a pregnancy test. If that is positive, you come to us for a pregnancy scan. And if it's negative, you'll do the whole process generally again, all being well. So if everything went fine in the IUI process, you don't always need to see a doctor again and have a review, because of course that can add a bit of a delay. Sometimes some patients choose to go straight into another IUI cycle as long as everything went fine with the first, other than it being a negative test. In terms of success rates for IUI, the one thing that I would say is different is that they are unfortunately a lot lower than IVF, and that's why it's really important to think of IUI as a whole package of treatment over 3 months, and ideally over 6 months, rather than thinking of it per cycle. Because if you're less than 35, the pregnancy rate or live birth rate is about 12 to 10% per cycle. So in reality, you can see how you're going to need 6 months of treatment before we know that we've given that a real good shot of pregnancy. Whereas we know that the live birth rate for an IVF cycle is around 37% for the same age category. And that success rate decreases kind of significantly with age. So if someone, for example, is 38, 40, they'd be looking more towards success rates of around 8%, for example, for an IUI cycle. So it is dependent on your own circumstances and your own investigations. But again, that's everything that we would go through at consultation. But that's a general overview of the process. Next, we'll talk through another option, which is shared motherhood, or reciprocal IVF, or shared parenthood. And with this, it is like an IVF cycle. So in a couple, one partner chooses to have a stimulation cycle. So this is where we give you injections to stimulate your ovaries so that we can collect your eggs. And normally you have about 11 days, 10 to 12 days of injections. You have a procedure where we collect the eggs, which is a transvaginal procedure with sedation. Then we've got those eggs in the lab and we fertilize them with donor sperm. And then we grow those embryos on for 5 days in the lab and create something after 5 days called a blastocyst. Now that blastocyst then is frozen generally, or sometimes you can have it put back fresh into the other partner. So this is where the other partner then chooses to carry the pregnancy, and they would have a frozen embryo transfer generally. So you can do it where we're freezing the embryo and then we're putting it back into the person carrying the pregnancy later. Generally, at Care, we have a package for that, which is a bit cheaper. So it's the most cost-effective option. You can do it fresh, where you have an IVF cycle. The one partner has the egg collection, and then 5 days later, the other partner would have the transfer. The reason that is a little bit more expensive is that logistically it's harder for the team to organize, and it takes a lot more work to get you ready for the treatment. So we would have to synchronize your cycles. So in general, we encourage patients to do it just separately, one cycle after another. That's generally how shared motherhood works. Now, if you're having shared motherhood, you will be supported by our donation team. And the only reason for that really is that it requires special attention to the consents that we complete during the process. And the reason for that is we need to make sure that you're both the legal parents of the child that's born. And unfortunately, UK law is a little bit outdated with this. So we really need to make sure that because one is effectively treated in the eyes of the law as an egg donor and then one as an egg recipient, we need to make sure that you're both the legal parents. And that's what the donation team do by making sure you fill in the right consents. But other than that, that consent process, as long as it's done correctly, is straightforward. You don't need to have legal advice or anything like that, like you do in surrogacy. Next one. So we've been through this already. I think so. I've been through the entire process there with IVF. Of course, IVF, whether you're doing it as an a kind of one partner is just having all the treatments, so they're having the stimulation, the egg collection, and the transfer, or if you're doing it as shared motherhood, and one is having the treatments and one is having the transfer. Either way, of course, the process is a lot more invasive. So that's why, of course, a lot of couples are put off by it, but initially, which I understand. The one thing that I would say to you, though, is that always bear in mind that the success rates are better. And if you're a little bit older, so if you're older than 35, 30, and you're more towards 37, 38, it's also worth thinking about the fact that IVF is also a way of preserving your fertility. So if you've got a good egg store, and we'll do some tests prior to a consultation to determine how many eggs we will think we'll be able to get at an egg collection. If you've got a good egg store and we create spare embryos, we can freeze those embryos and they're not going to go anywhere. We freeze them in our labs and keep them there, which means if you do have successful treatment, then of course you've got the spare embryos that you can then come back and use in a few years whenever you want to. And your pregnancy rate will stay the same as when you created those embryos pretty much. So that means if you ended up having your egg collection at 37, but then your transfer, when you're 43, you'll have the pregnancy rates of a 37-year-old, which is one of the main advantages of IVF, in that it's useful to think about how many children you want, not just now, and think about your age and what time you've got in order to be able to complete the IUI process. As a doctor, sometimes I can see the frustration with the IUI process because it is slow. Patients find it a little bit slow because you've got to do it each cycle and you've got to come for a scan each time. But it is a lot more of a natural way to do it. So there are pros and cons, and there's not necessarily a right or wrong. Sometimes there is something that we would advise more than another, but again, that's what we'd go through at a consultation once we've looked at your results. IVF, we've touched on a little bit, but what I'll go through is in a bit more detail how that works. So with IVF, we're stimulating the ovaries, as I said before, and that's typically for about 10 to 12 days. You have your egg collection under sedation, and before that, you will meet the nurse and they will go through all of this with you. And you're given dosing that's specific to you so that we try and optimize the number of eggs that we can get at an egg collection, because what's really important to improve your chances of success of having a family is the number of eggs that we get. So the higher the number of eggs, that correlates with the live birth rate. So that would be optimized by the clinical team that see you. And you have your egg collection, and then what I didn't discuss so much is everything that happens in the lab, which is kind of really important to realize. So you've got your eggs from the egg collection, and the important thing is that the number of eggs that you have from that egg collection decreases over those 5 days. So typically you have the eggs and they're not all usable. So about 8% of them are usable in IVF treatments. Then of those that are usable, typically about 75% of those would then fertilize normally. And then of those that fertilize, about half of them form that thing that we want 5 days later called a blastocyst. And the blastocyst is what we want to make you pregnant. And we look at that blastocyst down a microscope, and there's two parts of it. So there's the bit that becomes the placenta, which looks like a big clump of cells, and then there's the bit that becomes the baby. So we can see that down the microscope, and we look at that and we determine which is the best one to put back, and we freeze any spares for you. So this is the same process as to whether you're doing a shared motherhood, IVF as a single, woman, or surrogacy. So it's the same process if you're creating embryos. There is the option to test those embryos, and you can test them with either something called out of 10. And that monitors, basically, it's a video that we create of the embryos in the lab, and that's analyzed by artificial intelligence. The other way is with taking a biopsy of those embryos, and that's called PGTA, so pre-implantation genetic testing. So you would think by taking a biopsy of an embryo that's really small and fragile, you'd have a risk of damage, but actually this has become a pretty routine procedure these days. And the pregnancy rates are increased by doing this, and the miscarriage rate is reduced. And that again depends on age, but generally, if you've got a genetically normal euploid embryo, because you've tested it and we know it's genetically normal, then we know that the pregnancy rate is about 55–60%. So the clinical pregnancy is where we see a heartbeat on a pregnancy scan. So that is one way that sometimes we advise to do as part of the process to try and increase your pregnancy rate. So, and the reason that we do that is that we know that the main reason that IVF doesn't work is because the embryos that we create are genetically abnormal. So even in someone that is young, so if they're less than 35, about half of their embryos, about 40% of their embryos will be genetically abnormal. So, and that's because of the eggs. It doesn't unfortunately come from the sperm. So when we're doing IVF, we can eliminate those bad embryos by testing them genetically. And often same-sex male couples choose to do this as part of a surrogacy journey, because you will soon find out, if you're just starting out in this process, that a lot of surrogates are actually pretty well aware of the IVF process, and a lot of them will be kind of more attracted, for want of a better word, to someone who has got genetically tested euploid embryos than ones that aren't tested, because they'll know that they've got a higher chance of working and a lower chance of them causing a miscarriage. So it's something that we will always discuss with couples, same-sex male couples, using surrogacy. But we'll go through surrogacy in a second. Well, now actually. So same-sex male couples. So we offer across our group surrogacy, and we provide a really good service. So surrogacy, whilst generally kind of might seem relatively straightforward, because you've got someone who's healthy, or they should be healthy, carrying a pregnancy. You've got two guys who are not infertile generally, just wanting to have a family. So that, in general, you'd think that that is pretty straightforward, but actually it can end up being a little bit more complex, because the surrogates are often patients that have had multiple pregnancies before, and we need to ensure that they're safe and healthy people to be carrying your baby. And the journey is complex just because of the legalities around that in the UK. And that's why we've got a dedicated team to support patients through surrogacy. So in care fertility, I think probably what's unique with us is that we have a dedicated team of doctors that just do surrogacy. So I'm one of them. And what that means is that you get a team that is one, passionate about surrogacy, and they like seeing patients for this pathway. But also means that we work closely together with the surrogacy nurses to make sure that the pathway is as seamless as possible. There's two types of surrogacy, so straight and host. So host surrogacy, the baby is not related to the surrogate mother. So that is the most common way that we do surrogacy in the UK and at Care. It's very rare these days to do straight surrogacy. I think I've seen one case before, and that is where the surrogate is donating her eggs for use in treatment, whether that's going to be an IUI or an IVF cycle using partner sperm. So it's in the UK, the what we call the legal term is intended parent, so i.e. you. One of you needs to be genetically related to the child that the surrogate is carrying. So the surrogacy process, so the initial part of the process is to see the surrogacy team. So you don't actually see the doctors first, you see the surrogacy team first, and they will go through the different options. They will give you the cost estimates of what's involved before you start seeing the medical team. And they'll give you some guidance around the legal aspects and surrogacy charities and agencies. Then you will also have you'll have time then to see the doctor, and the doctor will go through your medical history. We get you to fill in something called a genetic questionnaire, and again, these are all kind of documents that are required by law. So because we need to, in the eyes of the law, we need to ensure you're suitable as if you were donating your sperm for treatment in someone else's treatment. So we have to almost act like you're a donor. So that's how we process you. It's as if you're donating your sperm to someone else. So it seems a bit backward and frustrating, but that's what we have to do. So, and that's just because someone else is carrying your pregnancy using your gametes. So we'll check your medical history. We check something called your genetic questionnaire, and that just essentially goes through your family history. You'll have some blood tests done. So therefore, lots of sexually transmitted infections and genetics tests. Then after the genetics tests, as long as they're okay, you'll then start quarantining some sperm. So the sperm quarantine process lasts for 3 months. So what that means is that you have to freeze some sperm. We keep it in our labs for 3 months, and then we repeat the infection markers again after 3 months. So after 3 months, that's when you can then start to create embryos for surrogacy in treatment. So it's a little bit more long-winded compared to a standard IVF process. And that's, like I said before, we need to process your sperm as if you're donating sperm for treatment to someone else. So that's why the quarantine process is there. And it's because we know that an infection such as HIV might not be present in the initial screening, and it takes 3 months for it to show in the second screening. So that's why that process is there. So you've done your quarantine, and then you're ready to create embryos, and then you would go through the IVF process. Either alongside that or after, so you can create your embryos first, or you might already have a surrogate. We'll support you in finding a surrogate, and we will see them. So there's not a right or a wrong order to do this, but lots of couples, as soon as they've decided this is what they want to do to start a family, they will get on and create embryos, because if you do find a surrogate, then often having the embryos ready is a bit more appealing. So that is an overview, very quick overview of the surrogacy process. Finding a surrogate is, I think, what a lot of couples worry about. And it is really variable. So sometimes it can take a long time. From my experience, it seems to be less difficult in some areas. So in Manchester, I don't know why, but there's loads and loads of midwives that are surrogates at the moment. And I've had patients where they've had to change surrogates and actually found a second surrogate relatively quickly. So there is this presumption and kind of stereotype that it will take, years to find a surrogate. And my experience is that that's not the case, although it can be. So it is really variable. But there are agencies that are listed there that support you with finding a surrogate. So it's illegal in the UK for an organisation like Care Fertility to help you find the surrogate. That has to be done by someone that's independent and therefore you'd go to one of those listed agencies. So Surrogacy UK is one of the most common ones. So the legal process is often what causes more concerns, because I'm sure those that are on the call that are looking at this type of treatment will know that there are sometimes more guarantees, for want of a better word, with having treatment abroad. And that is due to how the UK law is set up. So in the UK, the surrogate is the legal parent at birth. Now, this is changing and has been changing for the past 2 years, I think. However, it still hasn't gone through Parliament, so we're still stuck with the same legislation. So the surrogate is the legal parent, and the intended parents, which would be you, must apply for a parental order after the baby is born. So our job as your fertility clinic is to make sure that absolutely everything is in place, that we're really confident that you'll get a parental order at the point of birth. We can help you with legal advisors to support this. But the difficulty is that all of these kind of processes in the UK are not actually enforceable by law. Now, the reassuring thing is I've never seen a case where, for example, a surrogate's chosen to keep the baby or anything like that. Now, you will hear of it in the news, but it is incredibly rare. And that's why it's important to find someone that you build a relationship with and you trust. But there are, I would say, more people going internationally for surrogacy, but I would say that has its own challenges and it's very, very expensive. So it's more expensive than the UK. And often the surrogates are not necessarily appropriate people to be carrying the pregnancy. Now, we do and support international surrogacy, so that's part of my job. So we have a special team that look after these cases. And that's just because they're incredibly complex. So we need to ensure that if you're creating embryos and then you're going to use a surrogate that's abroad, that when you bring that baby back, you'll be able to bring the baby back into the UK. So we need to be 100% confident that that will be the case, because it can be really tricky with certain countries. So that's kind of the legalities of surrogacy. Sperm sharing, a lot of same-sex male couples or gay couples choose to sperm share, and that's probably because surrogacy, as we all know, is one of the more expensive treatment pathways, and it, of course, makes it more cost-effective. So I think it's £3,000, but Georgia will confirm that after when she comes on, which is the discount that you get from if you sperm share, the discount you get on your own treatment. So that's where you when you're going through the sperm quarantine process, you also become a sperm donor to add your own sperm to our sperm bank. So using a donor, so this covers both egg, sperm, and we've got an embryo bank as well. So donor sperm. So in this situation, often for same-sex couples, single patients, or trans men, or non-binary patients. So there's a whole host of patients that use donor sperm, and we've got our own sperm bank. How it works is you would request characteristics, you get offered a match, and then the sperm gets shipped to our clinic. Now, it can be a variety of length of time that can happen, depends on how picky you are with the characteristics that you want. In the UK, you only get limited characteristics, so you only get hair color, eye color, build, and ethnicity, and that is the same for donor eggs as well. So you would be offered a match, and then you would let us know whether that was appropriate. But like I said, it can be a kind of, sometimes if you're wanting something quite specific or you're a certain ethnicity that you want to match to, that can take a few months. Whereas if it's something relatively straightforward or you're more flexible, we can get you matched in as short as 2 weeks. Now, there are different options for sperm bank process, so you can use external sperm banks if you prefer. The key difference, I would say, is if you're doing IUI, if you're using our bank, you have to be matched per cycle. So before you do each IUI, you get matched with a sperm donor using our bank, which means we can't necessarily guarantee you the same donor. We will always try. Whereas the alternative of using an external bank is that you can buy as much of that donors that's available from that external bank. And when you've had a consultation, there's lots of external banks that we work with. There's a list on there. It's a little bit of an odd concept. If you're finding a sperm donor, you go onto a website on, say, it's European Sperm Bank. You find the sperm donor that you want, select it, add care fertility, whichever clinic it is, say Manchester, and then they would contact us and we would arrange the shipment. So there's the two differences, and it's completely up to you whether you want to use our sperm bank or an external one. All of our sperm donors are, of course, HFEA compliant, and they've all been screened and gone through the quarantine process that the same-sex male couples using surrogacy will have gone through. Donor eggs, of course, used by a variety of couples, but not just LGBT couples, but often also lots of heterosexual couples use donor eggs, and therefore there's a really big demand for donor eggs in the UK. So there's more donor eggs being used than ever, and that is what I would say as well, is that we're recruiting lots of donors all the time when we have our own egg bank. So if you have donor egg treatment with us, it's care fertility donors. It's not donors that have been bought from Europe or further afield. So it's the same process. You get limited characteristics, and we've got an app which is called Salve. When you're on the Salve app, you would be able to see all the donors that are available, and you match to an egg donor through the app once you're registered. So for the donor sperm, you don't need to see the donation team because it's relatively straightforward. For donor eggs, the consents can be a little bit different, and matching is, I suppose, a little bit more complicated, not for you, but just for the things that we need to input into our system. So you do need to see the donation team before you're using donor eggs. Both require implications counselling, so that's required by law, and that's where you see a counsellor that goes through the implications of using donor sperm or egg. So again, that is a law requirement, but it's probably a bit outdated because everyone on this call, when you have a child through donor gametes, it will be pretty obvious that you've used donor gametes, and therefore you know, you're probably going to be honest with the child in terms of how they came about to be in the world. Whereas for heterosexual couples, there's a lot more implications, I would say, for using or moving on to donor eggs, because they've often been through lots of cycles of treatment of their own, moving on to donor eggs, and that can raise a lot of questions. Particularly the UK has a law that once the child is 18, that they can contact the HFEA for information about the donor, which means that they'll get identifiable information at the age of 18, which again, the counsellor would go through with you. We've been through the donor egg process, I think. So fertility preservation is often used by patients going through gender reassignment. And that can either be fertility preservation with eggs or sperm. And not that this process is any different for transgender patients, but of course, there's different considerations that we need to make. So, for example, if someone is freezing eggs, they might have been on testosterone treatment for a length of time, and therefore we might give advice about when to stop that. And often patients won't want to stop it for obvious reasons. So there isn't kind of specific pathways for the transgender patients, but we need to be mindful that we're supporting these patients that have particular challenges with the process. So if you're going to really struggle with intimate examinations and that kind of thing, these are all important considerations to have before starting an IVF, not an IVF, a fertility journey. And again, what we would do as a fertility clinic is when you're freezing your eggs or your sperm, we would make sure that your plans for what you want to do in the future will be covered by the consents that you're filling in. And that's again because unfortunately the UK and the law, we need to make sure all the time that we're filling all the right consents in. And that's so that when you come to use them, if you ever come to use your eggs or your sperm that you're frozen, that you would be able to be the legal parent. So egg freezing is the same process really up until the point of an egg collection in IVF. So you have stimulation injections and then we freeze the eggs after the egg collection. Sperm freezing we've talked through already. We do a semen analysis and we also test that when we get the sperm out of the freezer after freezing it, that it thaws nicely so that it would be good for treatment. So usually this is completed in a few visits. So the next steps would be your consultation. That's me. So we would go through your history. We organize some test results before, and in terms of the test that you need, it really depends on what you want. So we've got the same package of pre-treatment bundle. And no matter, say you're a same-sex female couple, you can both have both of the tests. So because you might not know which treatment you want to do or who's having the treatment, and it is the same price. So that's what's quite good about the package that we've got available at the moment. So you'll have those tests and then we discuss them at a consultation and discuss the different treatment options. After the consultation, our patient services team will send you a full breakdown of the costs, and you'll also have the option to talk through the different treatment plans that have been talked through at the consultation and make sure what we're doing is right for you. So why choose us? So Care Fertility is a well-known brand across the UK, and we will support you in every step of the journey. We've talked through lots of the different teams that support patients going through these specific pathways today. And we'll also provide online support, and we've got different resources available on our website as well. And the good thing about us is that we've also got a big network. So we've got 16 clinics across the UK that you can see there. And often these clinics have also got smaller clinics, which we call satellites, meaning that you can have some of your tests in a clinic that might be a bit more convenient to you. We're also known for having really good success rates, and these were the recently published success rates. And actually, CARE's success rates since this publication have gone up even further, but we're above the national average for success. I hope that was useful. Lots of our teams are available on hand, as Georgia was saying, to support getting you into a consultation or into treatment, depending on what treatment it is that you're having. But I wish you all the best of luck, and hopefully I might see some of you along the journey. So just let me know if you saw me on here and you booked a consultation with us.